Hello, my name is Seth Rosenthal, and I'm chair of the ACR Commission on Radiation Oncology. And I'd like to welcome everybody to the RFS Journal Club, sponsored by the ACR RFS Radiation Oncology section. Tonight we have a special presentation led by Dr. Najib Mohiddin, who is chair of the Economics Committee of the ACR Commission on Radiation Oncology, and is also a member of the Astro Health Policy Committee and Astro Payment Reform Committee. Tonight, Dr. Mohiddin is going to try to educate us on letters and numbers, reimbursement and radiation oncology, and is going to hopefully decipher some of the very confusing alphabet soup which is out there regarding the changes going on in reimbursement. I think Dr. Mohiddin has prepared a presentation, and after that, Dr. Brian Robotic, who is a resident in radiation oncology at UNC in Chapel Hill and a member of the executive committee of the ACR resident and fellow section, is going to help moderate questions from the audience. So with that, I want to be respectful of everybody's time, and I want to turn things over to Dr. Mohiddin and Dr. Robotic.
Well, thank you, Seth. This is Najib Mohiddin. Thank you for that very kind introduction, and also thanks to Nancy Ellabrook and Brian Robotic for inviting me to speak here today, and to ACR staff for making this possible. So, I understand that there are quite a few residents on the call. So what I will do is start out with some basics about Medicare and radiation oncology reimbursement. Then I'll discuss the paper that was circulated, and that's Variations in Medicare Reimbursement and Radiation Oncology. And I'll also discuss another paper which actually just came out today in the open access journal Curious, and that's a radiation oncology physician practice in the modern era, and a statewide analysis of Medicare reimbursement, and this focuses on New York State. So we'll look at some data from that, and then if we have time, we'll look at how the changing landscape can impact radiation oncology. So as everybody knows, national healthcare expenditure keeps rising. It's gone up 5.8%, and for the last year that data is available, that is 2015, it is actually $3.2 trillion, and that's a big chunk of the GDP. It's about 17.8% of GDP. Medicare spending grew 4.5% to $646 billion, and Medicaid spending also grew faster, 9.7% to $545 billion. And there's a lot of talk about this because there are more enrollees in Medicaid, and one always comes across, is it because of the expansion of ACA that this is happening? Private health insurance also keeps growing. It grew 7.2% to a little over $1 billion. So this is data from 2014 looking at the national healthcare dollar. And at that time in 2014, it was a little less than the $3.2 trillion. It was $3 trillion, the national health expenditure in 2014. So as we saw in the last slide, health insurance accounted for 73% of the healthcare dollar, and we went over that in the last slide. But what I wanted to point out is out-of-pocket expenses is 11%. So a little over 1 in 10 of every healthcare dollar is coming out of pocket, and that's not good because that's rising too. So let's focus on Medicare benefit payments, and this is for the year 2015. Total Medicare benefit payments in 2015 from the Kaiser Family Foundation. This slide was borrowed from their presentation. It's $632 billion. And what we are going to talk about quite a bit is this small piece of the pie here. Physician payments of 11% and hospital outpatient payments 7%. Each of these other parts can be a 1-hour webinar, but this part is what we're going to focus on today. So Part B accounts, Medicare Part B accounts for almost all of radiation oncology payments, and it's paid through two systems, the Medicare Physician Fee Schedule and the Hospital Outpatient Prospective System. So where you practice has an important effect on how you get reimbursed. The vast majority of radiation oncologists practice either in the hospital outpatient facility, or in a freestanding facility. And per the last data that was available, 40% of our members are in freestanding facilities, and about 60% are in the hospital outpatient facility. So we also have to look at another part here, and that is professional and technical reimbursement. The work that the physician does is the professional component of a CPT code. And the work that is done by non-physician clinical labor, which in our case is primarily physicists, therapists, dosimetrists, and nurses, are components of the practice expense or the technical revenue. And also the technical revenue includes reimbursement for equipment use and supplies. So depending on where you are, if you're working in a hospital outpatient facility, your services, the physician services, are billed through and paid through the Medicare fee schedule. In a freestanding facility, most facilities bill globally. Both professional and technical services are through the Medicare fee schedule. And if you split bill, again, the physician and technical services are paid through the Medicare fee schedule. It's only in the hospital outpatient department that the technical services are paid through the OPPS. Okay. So both these systems are quite different. So I'm not going to get into the details of the differences between the two systems, but in the OPPS, that is in the outpatient prospective payment system, codes are grouped into ambulatory payment classification categories, and each one of them apparently use similar resources. It can be up to twice the resource used for the lowest value code. So for example, in the OPPS, and this is the quirky part of this payment system, 77295, which is 3D treatment planning, and IMRT planning, which is significantly more resource intense, are put in the same APC group. On the other hand, in the Medicare fee schedule, all CPT codes have relative value units, and a conversion factor is applied to these relative value units, and that conversion factor adds a dollar figure to those relative value units, and we'll look at that in a couple of slides ahead. So again, as we said, codes can be split into the technical or the professional or global component. And in the Medicare fee schedule, if you have a CPT code for 3D planning 77295, that has very different physician work and practice expense compared to IMRT planning, and they are paid very differently. So these two systems are quite dissimilar when it comes to how technical codes are valued. So as you saw in the prior slides, as far as physicians are concerned, physicians who work either in the hospital or in the freestanding facility, and for the technical reimbursement in the freestanding facility, everybody looks to the release of the proposed rule. And without fail, it usually comes out before the July 4th weekend, ruining almost everyone's July 4th weekend if you're on one of these committees which has to review these proposed rules. So the proposed rule comes out in July, and then specialty societies write in their comment letters objecting to whatever they need to, based on what is in the proposed rule. And then the final rule is published in November, and the final rule publishes the relative value units for the CPT code, and those values apply for the following year. So just to recap, the total work RVU is a component of the work RVU. What is the work RVU? The work RVU is the physician's time, mental effort, the skill, and stress and intensity of work needed to perform a procedure. That is the physician work RVU. Now, practice expense is split into direct and indirect. We're just going to focus on the direct practice expense here. The direct practice expense, as I mentioned before, is if you have, let's say, for example, you're doing an IMRT plan, you have done the contouring, you have decided what the critical structure doses are, you've kind of also helped in outlining the critical structure, and then the physicist comes in, and then the physicist runs many plans. They have to do a QA of the plan. So the physicist's work is all technical revenue. The time that the physicist spends on the treatment planning machine and the time that you spend on the clinical treatment planning machine is equipment use time, and that accounts to the technical practice expense. And so that's how this is split up in the Medicare fee schedule. Work RVU is physician work, practice expense RVU is the technical revenue. So the process of care in radiation oncology involves a series of face-to-face interactions. That is where you're directly in contact with the patient. And then there are interactions which are non-face-to-face. When you're doing your treatment planning, when you're contouring, you're not directly in face-to-face contact with the patient. And sometimes that's very difficult for us to explain at the RUC. The RUC is the body where when you are developing a new CPT code, you have to present the work, discuss the work, and a relative value unit is assigned to that work. Now, for the neurosurgeon, they can say that we are operating in the brain, we're near the brainstem, it's near the blood vessel, everybody understands that. But when you say you're sitting in front of a computer and mapping out critical structures, it's very difficult for someone who has not worked as a radiation oncologist to understand the intensity of that work. So that's where the art and science have to come together, these RUC presentations, to get across how intense this work is, because you are really doing critical work, trying to spare these critical structures. If the dose falls off onto the brainstem, you can have some critical damage, significant damage. So there's a lot of risk in the work that you do. So in this series of codes, what we see is the patient is initially seen, and that's in an E&M visit. Then you have a series of codes where you're preparing the patient for treatment. One is some work is cognitive work, like clinical treatment planning, deciding what kind of dose, what kind of fractionation. Then you simulate the patient. Then there's planning and dosimetry, where you actually create the physical plan. And then there's actual radiation delivery, and that may be delivered with IGRT. And then once the patient starts treatment, you have to manage the patient through the course of treatment. So that's the radiation treatment management and then follow-up care. So if you look at our series of codes, there are some codes which are just professional work alone. That's E&M coding, clinical treatment planning, and weekly management. They're all just professional service codes alone. And then there are codes which are a blend of PC and TC, because you can't simulate a patient without a therapist or a simulator. And for a treatment planning, we went over that. You need the physicist, you need the dosimetrist, and so on. Now, treatment delivery is purely technical, because you have the therapist, you have the equipment, and you have the patient. The patient is lined up on the table. The therapist treats the patient. There is no direct physician work with treatment delivery, But the work that we do in managing patients during treatment delivery is part of radiation treatment management. So how are we paid? When you look at, this is our weekly management code, 77427. So it has work RVU, practice expense RVU, and malpractice RVU. And at the RUC, these are all assigned a relative value number. So this is the work RVU, total work RVU is 5.2. When you blend in the work, the practice expense, and the malpractice, that is multiplied by the conversion factor that is published every year in the final rule. And for 2017, the conversion factor was $35.8. So you multiply the conversion factor by the total RVU, that gets you the dollar amount that you're paid for providing this service. Okay. So let's look at a series of our codes. And some of them are professional service only codes. That 77435 is the CPT code for SBRT management. 77427 is weekly treatment management. Look at the difference in the total RVU. SBRT is 3 times the value of weekly management. Why is that? That is, SBRT is up to 5 fractions. It is a one-time charge, so you're paid once for managing all those 5 fractions. It is much more intense than the daily radiation treatment. You're giving much higher doses per fraction. You're giving 20 gray per fraction times 3, so 60 gray for lung cancer, something like that. So because of that, the time is more, the intensity of the work is more. You have to directly be present and supervising this. And also, in SBRT, image guidance is rolled into the value of this code. So that's why this has such a high value. So the actual reimbursement for this would be multiplied by the conversion factor if you are a Medicare patient. Now, so on the other hand, when you look at IMRT planning, for the actual work that you do, you get 8 RVU, but the facility or the freestanding facility in this case gets 46 RVU. And that's because the physicist time is counted in this, the therapist time, the treatment planning computer time, the time that is taken for the QA, all that goes into this. So this is a technical revenue heavy code, whereas these are both professional RVUs, the top 2. So then we come to treatment delivery. There is no work RVU, but there's 11 RVU for IMRT treatment delivery. Now, IMRT treatment delivery is a daily treatment charge, which is multiplied, let's say if you're doing 35 IMRT treatments or 40 IMRT treatments, that's multiplied by 40. So that adds up to about 440 RVUs. So in total, that counts for a big chunk of the reimbursement in a freestanding facility because it's a daily repetitive treatment. So this is just data collected from a large billing service, and this pie chart shows you what is the split, what is the makeup of codes in a hospital-based facility. And what you see is radiation treatment management codes, be it weekly management or SBRT, accounts for a significant portion of the professional reimbursement. Okay? So this is what a physician in an academic center or a hospital outpatient facility, this is what his reimbursement profile would look like. Treatment management accounts for a big chunk of it, then physics and dosimetry charges, including IMRT planning, basic dosimetry calculations, that's about 26%. If you do IGRT, which many of us do for IMRT treatment delivery and for some 3D treatment delivery, the professional component of those IGRT codes adds up to about 13%. E&M codes are 11%, and the rest are all up here. Now, look at this. So this is about 31%. That is treatment management. What happens in a freestanding facility where you bill globally? Treatment management accounts for 6% of the global revenue, whereas treatment delivery accounts for 40%, sometimes even higher than that. And physics and dosimetry, with all the technical revenue heavy IMRT planning, SBRT, and so on, that accounts for 28%. So treatment delivery is the biggest piece of the pie in the freestanding facility because of global billing. And as I said before, it's a charge that's done every day, whereas many of the other charges are either once every 5 fractions or just once for the entire course of treatment. So with that background, let's look at the first paper, and that paper was published in the Red Journal in 2016. And so basically, this is the Medicare provider utilization payment data. So Medicare decided to publish data on Part B services provided by all physicians. And radiation oncologists, some radiation oncologists figured in the top 20 in these lists. And what is clear is that is erroneous, just like some medical oncologists featured in the top 20 list in these, because you have to compare apples with apples. So what was the problem with this data? Well, let's look at it. So it looked at just over 4,000 radiation oncologists, 4,135 radiation oncologists who received payment from Medicare in 2012, and that totaled about $1.5 billion. Now, the paper said the median reimbursement was $146,000, with this range, $69,000 to $423,000. Of the 4,135, 37% billed globally. And not surprisingly, with the information that you have from the past slides, you can see that their median Medicare reimbursement was $606,000, whereas for all the other radiation oncologists, that is mainly radiation oncologists who are billing PC only, professional services only, it was $93,921. So this is not what the physician took home. This is for the equipment, for paying the physicist, the dosimetrist, the cost that the facility incurred. All of that is coming through this payment. So this is not something that the radiation oncologist pocketed and took home, which was what the kind of impression that was given at the time, which is what made these authors publish this paper. So let's dive a little deeper into that. Now, what were the top billing codes by Medicare reimbursement? So 77418 is IMRT treatment delivery, and that accounted for nearly a third of all payments made to radiation oncologists in this data set. So, and if you look at it, just the treatment delivery of IMRT doesn't really amount to a third of all the work that we do. If you look at, we're doing brachytherapy, HDR, LDR, we do SBRT, we do treat a ton of patients, see a ton of patients in clinic. So somehow IMRT, because of its technical reimbursement, kind of accounts still for a bulk of the total piece of the pie for reimbursement in the freestanding facility. The next code on the list, the topmost code, is weekly management. Now, this is a code billed by every radiation oncologist, and that's why the number of times it was billed is pretty high, 1.1 million times, and that accounts still significantly lower than the sum total of all IMRT payments in that data set. About a third of that is weekly management. Now, what is interesting here is if you look at these codes, 77014 and 77421, these are codes that are currently used for IGRT. So it's interesting to see how IGRT utilization is increased. This was a code that was not there about 7 years ago, 8 years ago. Now this has become one of the most commonly utilized codes in radiation oncology, primarily because we're using it for image guidance with IMRT and sometimes with 3D CRT. Okay. So this slide looks at E&M visits. And the reason I show this slide was I was quite surprised that these are new patient visits. So you're seeing a patient in consultation, and 48% of the time, radiation oncologists were billing the top new patient visit code 9921205, which means that you took a comprehensive history, comprehensive exam, and it was a highly complex medical decision making. And that may be true, but I doubt that every prostate would fall in that category. So I'm a little surprised that the most commonly billed new patient office visit was a 99215. I would have expected it to be a 99204. Interestingly, if you compare this data with internists bill a new patient visit at 29205 about 17% of the time. So, and it's very possible they're just not seeing that kind of complex cases that we are seeing. But I was a little surprised that 50% of the time we were billing a 99205. Now, this is E&M visits for established office visits. This is typically follow-up. And as we expect, 54% of the most commonly utilized code is 99213. Some of these are undercoding, but this is almost like a nurse visit. I think when a physician sees a patient for follow-up, even for skin cancer, prostate cancer, and so on and so forth, it rises. You do take a history, you do a physical exam, you make a list of his medications, and you have a recommendation. So it usually is around a 99213. Now, about 30% of our radiation oncologists are billing, let's say, codes of higher complexity, and 6% are billing 99215. So here is a list of radiation oncologists, and I'm pleased to say that not many of us bill this 99215 established office visits, that is level 5. But there's 2% of us who are billing this all the time. Every patient that we see, these 2% of physicians see are a 99215. And I just find that that is something that is sticking out for an audit. When you look at something like this, that just cannot be possible that every patient that you see is a complex, highly complex level 5 visit. This slide tries to look at Medicare reimbursement by gender, and what is interesting is there have been a number of publications which have looked at gender disparity, and it is clear that there was an article in the JAMA, there was an article by Dr. Jagsi about 2 years ago, and then there was a survey today from Doximity which looked at differences in multiple different specialties in physicians who are working full-time, 40 hours or so not part-time. And they saw that there was a gender disparity with males being paid more than females. But I don't think you can make that same conclusion by here in this, because Medicare doesn't reimburse males versus females differently. That's what it can reflect is the number of services provided were significantly lower by female physicians than male, maybe part-time, maybe I don't know what it is, but I don't think you can make an argument that Medicare reimbursement there is a disparity with male and female. There just isn't, because that's not how Medicare reimburses. So this is Medicare reimbursement by rurality. And based on the cost of living adjustments in GIPSy, you would expect that the rural areas are paid lower than large metro. However, this is kind of all over the place. The best payments were in the smaller metro areas and followed by the rural areas. And I think, again, that reflects the services provided. In the large city, the number of services provided were significantly lower than in the other places. And that's why the total reimbursement was also lower in the larger metro area versus the rural area. So I now want to go on to the next paper, which really is also a very interesting paper. Just came out today on the online journal. It's an open access journal, and anyone can access it. So this looks a lot at the statewide analysis of Medicare reimbursement and looks at New York State. So there were 236 New York State radiation oncologists. New York State radiation oncologists in this data set for a total reimbursement of $91.5 million. So again, when you look at it, freestanding centers which bill globally, the mean global Medicare reimbursement was $832 million. Sorry, 832,000. I think I can't see my whole screen, but anyway, that's all right. When you bill just professional reimbursement, that is hospital-based providers, their average reimbursement was $115,588. So again, that ratio is somewhat similar to the last slide that we saw. This is from 2013. The other study was from 2012. So this looks at the percentage of radiation oncologists by practice type. 58% work in a hospital-based facility, which is kind of what we know from the larger national surveys. 5% work in both hospital and freestanding. And of the 37 who bill globally, 37% which bill globally, 21% work in urology-owned practices, 15% where it's a predominantly hematology oncology run practice, and 64% are the rest. So what the authors then did is, just looking at the freestanding facilities, looked at Medicare reimbursement per physician. So I'm just going to see if I can move this out of the way, because for some reason my slide is getting blocked. Okay, Medicare reimbursement per physician. And what it found was the urology-based freestanding facilities, it was 1.328 million, whereas at the hematology oncology freestanding facilities, it was 754,000. And other freestanding facilities run by radiation oncologists, it was 691,000. So this was significantly higher. That is, the urology-based practice, Medicare reimbursement per physician was significantly higher than the other two sites of service, the other two freestanding facility types. So why was that so? So one of the things is on-treatment visits. So on-treatment visits would be a weekly management charge, would be an on-treatment visit. So on-treatment visits was significantly higher in the urology-based practice compared to the other two freestanding facility types, and it was actually the lowest in the hospital. The hospital was 209, and the urology-based center was 424 per year. and then look at IMRT utilization. So now how they calculated IMRT utilization is not entirely correct, but it's a good estimation. What they did was they looked at the total number of 77301s, which IMRT planning. That was the numerator, and the denominator was IMRT planning 77301 and 3D planning 77295. Now, there are patients who get simple or complex dosimetry plans and brachytherapy plans. So it wasn't the entire universe, but I doubt that in a urology-owned practice center that people are doing seed implants and other things. So I think this is pretty accurate. What it showed is 76% of all patients in a urology-based facility was treated with IMRT. And in the hospital base, it was just 43%. In other freestanding, it was 58 and 32. Overall, if you look at freestanding versus hospital, the freestanding was around 53% IMRT, and the hospital was 43% IMRT utilization. So what was their conclusion? Well, their conclusion was that higher Medicare payment was significantly predicted by the type of practice structure with urology-based and hematology, oncology-based practices accounting for the highest total reimbursement and also on-treatment volume. And also, urology practices demonstrated significantly higher IMRT utilization. None of this is surprising, but when you see the actual numbers, the difference is pretty dramatic. So I'm going to come back to that slide in a minute. So what has happened to our field when we step back and look at this? When we look at these two publications, this is the Medicare allowable charges in the Medicare fee schedule allotted to radiation oncology. Another way of putting it is this is the size of the radiation oncology pool in the Medicare fee schedule. And when you look at the data from 2003, this reflects actual data from 2 years before that, 2001. IMRT code came out in 2001, if you recall that. And before that, the size of our pool was 810 million. Then IMRT comes out, and within I'd say 5 years, it doubles to 1.6 million. And there's been articles in the New England Journal of Medicine showing that our field had one of the most rapid rises in exceeding these SGR targets. So this is the reason why. So so radiation oncology pool size literally doubled in 5 years. It peaked by 2013, which reflects data from 2011 at $1.98 billion. And then, as we know, 2012, 2013, 2014, every proposed rule, there were cuts and cuts and cuts. And now it's down to $1.726 billion, still very respectable. On the other hand, rather surprising, it's interesting to note that on the OPPS side, the amount of money that's paid to technical services of radiation oncology has been on the increase. Now, this is also because IMRT treatment delivery codes in the APCs have remained not just stable, but because IGRT is packaged into those IMRT codes, the code values, because of the methodology in APC, there has been a steady rise over the past few years in the APC reimbursement for IMRT in OPPS. So, because of the cuts in 2016, as I was showing you in a prior slide, in 2016 in the proposed rule, 9% cut to radiation therapy centers, 3% cut to radiation oncology, and so on were proposed. So again, ACR, ASTRO, we all fought the good fight and took it to Congress, and Congress came out with the Patient Access and Medicare Protection Act, PAMPA. And what it basically did is it froze the values at the 2016 values for 2 years. So for 2017 and 2018, the treatment delivery codes and the image guidance codes have been frozen at the values of 2016. As a result, when you look at our impact table, this is the Medicare fee schedule impact table. So in 2017, this is our pool size for radiation oncology, and small number of facilities are called radiation therapy centers. The impact on work RVU changes is 0. That means there's no we will not lose any money from a professional reimbursement. Neither will there be any loss in technical revenue, because this is also impact of practice expense RVU changes is 0. There have been years when it has been lower. The year in 2016, for example, it was cut by 2% for a variety of reasons. The utilization factor, which we won't get into, went up, which meant that the number of hours that these machines were being used were calculated at 50% of the total time the machine in a 5-day working week. That went up from 50 to 60, and it was supposed to go up to 70, but because of PAMPA, it was frozen at 60, but that accounted for the 2% loss in 2016, but since then there has been no change. So the question is, what will happen in 2019 when PAMPA runs out? There is some uncertainty, and as you know, we have put through the RUC new values for our treatment delivery codes, because ACR and ASTRO were asked to revalue the treatment delivery codes. It has been revalued, but those values have not been accepted by CMS, so it's kind of sitting out there. On the other hand, what's happening to utilization? So a lot of great data on hypofractionation. Data-driven information has allowed us to reduce the number of fractions for breast cancer, for prostate cancer. And then we also have insurance. You have revenue benefit managers with whom I'm sure all of you interact every day, trying to fight for your patients to allow an MRI to be done or a PET scan to be done. And now they also tell you that you have to treat a patient in X number of fractions, and beyond that, you get pushed out to a peer-to-peer review and so on. So all of these pressures are driving down the number of fractions, and also there are decreased indications for radiation, active surveillance for prostate cancer, elderly women with early breast cancer, omitting radiation, and so on and so forth. On top of all those pressures, we are also feeling the heat from alternate payment models. So we'll come to that in a minute. So where are we in this new healthcare landscape? So we are here. We have MACRA, MIPS, and we also have the promise that by 2018, 50% of all Medicare payments will be tied through to alternate payment models. So I think we're going a little bit slow, so I'll try to speed up here. So what is the new world we live in? So FGR has been repealed, and we have 2 tracks: the merit-based incentive payment system or alternate payment models, advanced alternate payment models. And if you participate in advanced alternate payment models, there is a 5% incentive to participate in that. You get a 5% bonus for participating in advanced alternate payment models. Under the merit-based incentive payment system, the bonus is going to be based on quality, and radiation oncology has a specific group measure. Cost, which is not applicable this year, So for 2019, cost is not going to be taken into account for radiation oncologists, but I think in going forward, one has to be cognizant of that. One would like to know, how is Medicare going to calculate this? We don't have to submit anything. They're going to calculate it from the claims data, from our claims data. So does it mean that if I don't treat all my breast patients in 16 fractions, I'm going to be classified as an expensive provider? If I don't treat my prostates in 30 fractions, then again, I might be an expensive provider. So we don't know whether it's going to be looked at by ICD-10 and utilization, or just across the board expense. So it'll be important to see how that plays out in the future. The other categories are improvement activities and advanced care information. So if you are working in a hospital-based facility or in a rural area, for 2019, you don't have to be in any of the EHR-based advanced care initiatives. So 85% of your bonus calculations will be based on quality and 15% on improvement activities. All right, so coming to alternate payment models. So what are the alternate payment models out there which Medicare considers as advanced alternate payment models? There are at least 5 of them. One of them is relevant for us, and that is the oncology care model. So under the oncology care model, one moment, let me see if I can move this thing out of my screen. Yeah. So under the oncology care model, it's a 6-month bundle that starts with the initiation of chemotherapy or hormonal therapy. And what is very important is this 6-month bundle includes all Part A and Part B services. So when you say Part B services, we just talked about Part B services and radiation oncology. It includes all of radiation oncology in that 6-month bundle if radiation oncology is provided in that 6-month period. So the way this is calculated is it's a fee-for-service payment for the fee-for-service payment. So everybody's paid on a fee-for-service basis, whether you're a radiation oncologist or a medical oncologist. There's a practice benchmark by disease site and practice, and there's a per-patient benefit that is paid $160 per month. And at the end of the day, if somebody's running this bundle payment, it is in their interest to limit radiation. And let's say if you think neoadjuvant chemotherapy and radiation is important in esophageal cancer, but probably the NCCN guidelines say you can use neoadjuvant chemo alone too, which is equivalent. Guess what? You probably won't be included in that treatment protocol. So I think you have to really guard against underuse of radiation in any of these models. And that's a big threat for our field. When you design an oncology care model, and a radiation oncologist is not a key part of that model or involved in creating that model, it is even though Medicare says it's monitoring the use of radiation, there is a big risk for radiation oncology. So, how are we doing on time? So we've got about 10 minutes. I'll try to wind this up. So one of the alternate payment models that's being worked upon, ASTRO is working on an alternate payment model to move away from fee-for-service towards value-based care, and it's a model that looks at guideline adherence, and it is looking at 5 primary disease sites: breast, lung, prostate, rectal, head and neck, and 2 palliative sites, brain and bone mets. And this will be looking at how will this be costed out? The details are being worked out. They will look at your practice. They will look at the regional practice and national averages and so on. So there is a lot of work that is going on in this area, which is critical to be sure that we are not just tied to fractionations, because when you're tied to fractionations, and when there's when you're in an era where there's hypofractionation for almost every site, the economics of your field could be disrupted unless you move away to a more comprehensive episode-based care package. So the challenge for us is to establish a value-based, sustainable, economically attractive practice environment in radiation oncology, and to transition to an aggressive engagement in quality. And we have to figure out how to cut the edge in this new medical context and address the cost issue at the same time in some way. But I don't think we should not look upon ourselves as being the big spenders in Medicare. You saw the size of our allowed Medicare allowed charges. And even if you add in the OPPS, it comes to about $3.4 billion in all. And then when you look at the costliest drugs that Medicare had in 2015, just hepatitis C, Harvoni, is $7 billion. Then you have Revlimid here, which is used in multiple myeloma, which is $2 billion. Just one drug is more than the entire Medicare fee schedule allowed charges for radiation oncology. Now, why is that? Because Revlimid is an expensive drug, and when you give it for maintenance in myeloma, it is effective, but you have to take it every day till somebody relapses, which may be years. So there is a lot of cost that Medicare can control. One of them is in the management of age-related macular degeneration. There was a publication in Health Affairs recently where they said just by changing from Lucentis to Avastin over 10 years, Medicare can save $18 billion. And this wasn't written by some health policy guy. This was written by ophthalmologists. So I think one of the things is to divert Medicare's attention away from radiation oncology, but I don't think that's happening. And I think if you have the time, maybe you can, on May 3rd, CMS is having a call-in for discussions on an alternate payment models for Medicare, because they have to, under PAMPA, they have to make a report to Congress on what they have done with alternate payment models in radiation oncology in the freestanding facility. So with that, I'm going to stop there. I think we have about 5 minutes for questions. Thank you for your attention.
Well, thank you, Dr. Mohideen. That was a very informative and in-depth and at times very confusing presentation of how we actually go about our reimbursement center funding. And I think as much information as you provided, it's definitely clearing up the view for a lot of us. To start off with, I guess for questions, we got one or two here which are teed up, but I'd like to start off with, I think really the question which you alluded to at the end is, how can we kind of help with the decision-making process with this, and who ultimately will decide these decisions for us?
Right. So ultimately, when we look at our practice mix, because of the fact that cancer predominantly occurs in the elderly, 65 or older, whichever way you look at it, Medicare is a significant portion. Medicare will always be a significant payer for us. So, what we have to do is there's no doubt that despite the change in administration and all of that, there is going to be this push towards alternate payment models. And what we have to do is to work collectively getting input from all sites of service, freestanding, academic, work towards developing an alternate payment model will work for everyone. And when we were with CMMI recently, they alluded to even having site-neutral payment. That means having the same kind of payment structure, whether you're in a hospital or in the freestanding. I think it's working through CMMI, making sure that the interests of all our members are reflected in this payment module, that we will have the best case to put forward. Now, it doesn't help having these isolated examples of freestanding facilities, which are urology-owned, running away and making 3 times what other facilities make. That's not the true picture. In reality, we use our technology very wisely. Where patients need IMRT, it's definitely, we should use it, head and neck, prostate, you name it. But just treating early stage prostate cancer, we've got to get away from that. We've got to get away from just basing our economic model on fractionations alone. It has to be based on taking care of an episode of care for a patient who has cancer and needs radiation. And we also have to be responsible to manage our patients. So if a patient needs IV fluids and is dehydrated or needs antibiotics, we can't just send that patient to the emergency room where the costs are higher. We have to own some of those responsibilities and costs. And that's the way to make a real difference here.
We have a question that came up is, will these slides be available? Yes, the answer is tomorrow. They should be available online for those who are interested or weren't able to make the entirety of the talk.
Absolutely.
That is the totality of our questions right now. We can give it a minute if people have come up with more questions, but Dr. Mohiuddin, I would like to thank you again for a very informative talk.
Well, thank you.
Nadeem, I'd like to thank you for your talk, and Brian and the RFS section for hosting this. But I guess I have a question for you about the alternative payment models. Do you think that those are actually going to be implemented in 2019, or are we looking at rules in 2019 and implementation later? I have to say, as confusing as the terminology is, the timeline is even more challenging.
Right. The timeline is more challenging, and you really have a 5-year timeline where you may get a bonus after 5 years. I think 2024 or so, there is no longer a bonus. So one of the impetus in moving towards an alternate payment model, if you wanted to get the bonus, I doubt that, it's very ambitious to think that something is going to be ready that quickly. Because what is important is also to model, there have been some preliminary models on the bone metastasis model to see if it will work out in this manner. But if you're including everything, including brachy, SBRT, protons, everything, you have to really see if the model works out. And then what you have to also be, what CMMI has to work out is, what are we responsible for in terms of management of side effects? How are they going to recognize that this is a side effect that's caused by radiation oncology and can be attributed to us? That is very confusing. So if a patient who has head and neck cancer gets chemoradiation and gets admitted to the hospital and requires care as an inpatient, how are they going to attribute care to us and to the medical oncologists? And secondly, how are they going to operationalize this whole new payment structure? So there's so many things that haven't been worked out. So I think submitting a proposal is one thing, and working through it, and it will take time. I don't want to say give any dates here, but I don't think it's that straightforward to operationalize these new models.
And actually, in the course of this conversation, we actually did have a couple of questions which popped up. If we have a moment, please.
Sure.
The first is there an understanding of how costs for hospital admissions will be considered in the episode of care bundle payments? And kind of a part of that is, for example, what about patients needing admission for PEG tubes, et cetera, during head and neck irradiation?
Mm-hmm. So that's a great question. It's so when you look at hospital admissions, the current way that Medicare assigns or wants to attribute this is mainly through claims data and ICD-10. So it's a very crude system. So currently that is very difficult to do. So if somebody is admitted for not any symptoms, but just for PEG tube placement, I don't think that cost can fall on radiation oncology, because that PEG tube is being placed to prevent much more significant expenses down the line should this patient not have a PEG tube. So how they will calculate that based on the current model that they have is very difficult to say. Having said that, what's happening so the American College of Surgeons had come out with episode grouper, where using very sophisticated software and also data inputs, they can take an entire episode and split it up into, who's responsible for what component of that care. It's mainly now used for surgical episodes of care, but I think there will be a time when this will also be for other episodes too. So the short answer to your question is there is no way right now that admission for PEG tube can be attributed to radiation oncology. But also the other side is there are some admissions that may be directly a cause of radiation. Let's say severe esophagitis, and the patient comes in, cannot eat, needs IV fluids, needs some kind of emergency parenteral nutrition, all of that. That could be a significant expense that's transferred to radiation oncology. Therefore, whenever a payment model is built in, there are side effects which happen, let's say, less than 2% of the time, as is said in the ASTRO model. Those should be paid outside this payment model. Similarly, if somebody has a massive heart attack, and maybe the patient was on hormonal therapy for prostate cancer, it's very difficult to say how much was caused by the hormonal therapy, which was needed for his locally advanced prostate cancer, and how much was inherent cardiovascular disease that the patient had. So there's going to be these gray areas, but I think there's no doubt that certainly side effects that we cause, like management of mucositis as an outpatient, management of hydration as an outpatient, some of these costs will be attributed to us.
Yeah, and the person posing the question has another follow-up, and I think this kind of works along the lines of, hopefully they'll allow me to add a little bit, but will this generate a negotiation amongst radiation oncologists and the other providers in terms of what the splits for their bundling will be? Because if radiation oncologists, for instance, are managing different side effects or are outsourcing the care for these side effects, where would that come into the bundled payment model, and what the respective cuts from the fields will receive, and what the cost burdens will be carried by each provider?
In a model like the episode grouper model that the ACS Brandeis has proposed to PTAC, and which was, let's say, partially accepted, you may be able to if these attributions are shown correctly, you may be able to negotiate what is your component of that care versus somebody else's component of the care. In the current models, that's going to be challenging. So let's say tomorrow ASCO comes out with a model for management of breast cancer, and we have a component. So there's a radiation payment model for breast cancer that's slotted into that. And during the course of treatment, the patient has some morbidity that necessitates the patient be admitted, say acute pneumonitis or something like that, admitted to the hospital for IV steroids or something 3 months after the radiation is done. Now, at this point, there's no mechanism to negotiate that care, but I think that's going to come up when you have different specialties working together within a payment model. Right now, under the oncology care model, all the savings go to the medical oncology practice. So if they prevent a hospital admission, so it's in their interest to have these big symptom management teams. They have to have 24-hour access so that they can prevent an emergency visit and they can prevent an inpatient admission. So compared to the previous year, if they manage to save on that, then that is a direct, they get to share in that savings. So that model is being built into the oncology care model. Doesn't mean we as a radiation oncologist are going to get any part of that unless you have a model that either blends with that or where you say you're responsible for this portion of the care, and if that is prevented, then that saving comes to you.
Okay. And I guess one last final question for 1 minute is, thinking about the future and new technologies, where does reimbursement for some more experimental techniques come into play? And will there be an allocation for those as they have been in the past, or will there be a new model for that as well?
No, actually, that's a great question, because you cannot stifle innovation in any field. And those innovations, trials, and new technology has to be paid outside the bundles and outside these models. But I think what may come is there might be a finite period of time. So they will say that, well, you have this great technology. We will pay for this for X number of years, but we want you to start doing clinical trials right off the bat, that you have data at the end of 5 years or 4 years to say this works or this should be paid at the current technology rates. So that's the kind of pressure that's going to come on. But initially, for new technology, it has to be outside these models. And when they mature and when they're useful or when they've proven their worth, the models have to be adjusted to take care of this new technology.
Well, I think with that, we will bring this session to a close. Again, I'd like to thank Dr. Mohideen, and I'd like to thank all of the ACR staff for their help and coordination and making this a very successful webinar. And to everybody else, have a good evening. Thank you, Doctor. Thank you, everybody.
Thank you very much.